For our next case, we're going to bring in Special Agent Rosa Braga-Mele. She's trained in a wide variety of cases and martial arts as well, so she's able to take down these cases pretty well. Yep. Rosa, can you take us through this next problem we have here?
Absolutely. So this is a case of astigmatism post-toric IOL implant. And I have to disclose that I am a consultant for Alcon, J&J, and Zeiss. I have a patient, a 56-year-old lawyer. Thank goodness he was a corporate lawyer and not a malpractice lawyer. His axial length was 24.46 millimeters pre-op with a sphere of -450, a true corneal sill of +350, and an axis of 90. And his corrected distance visual acuity was 20/30. He just couldn't read his legal material anymore, was finding it difficult in a dim courtroom to be able to see stuff. So he wanted to proceed with cataract surgery and have a toric IOL implanted. However, his post-op data maybe wasn't exactly what he wanted. He ended up being 20/50 uncorrected distance visual acuity with a -0.25 sphere, a residual +1.5 flipped axis at 5 degrees, but corrected, he did go to 20/20, so we knew there was no true ocular pathology, but he's not happy. So this is a case of residual cylinder. So we're going to have you vote. We're going to have you vote 3 times. We will correlate the data, but we'll show you your last vote of what's going on. So what do you think is the most likely cause of residual astigmatism in this case, or any case? Corneal surface disease with inaccurate measurements, misaligned or rotated IOL, posterior corneal astigmatism that became unmasked, poor calculations, or surgically induced astigmatism. And these are interesting cases because it really could be any one of these at this point in time, right, Dr. Ahmed?
Yeah, I think this is a good differential. So let's see what people feel are the most common cause. Yeah. Are we gonna show the results here?
Let's show the results. Okay, a misaligned or rotated IOL, which is probably the first thing I would think of if I was looking at this. Oh no, did the lens slip? So let's go on to this. So everything did look perfect.
Yeah, but how did you mark the IOL?
Well, I use the Davis one step, and what's important that I'm showing here is that I always get the patient to sit up. I do it in the pre-op area, and I mark with them looking at my nose, or if you want to wear the goggles to see a little bit better and have them look at the light. Make sure the head isn't tilted. Make sure they're not lying back, because there is cyclorotation induced if they're flat. And if the head is tilted, obviously the IOL is not going to be aligned properly. And then, which IOL did I implant? So I implanted a 16.5 for approximately 3 diopters of what I had calculated of corneal cylinder. So I have a copy here of the toric IOL plan to cross-reference.
But Special Agent Rosa, I know you always have a resident in your OR.
Unfortunately. Oh, did I say that out loud? I love my residents.
That's what she told me. So, were you running late that day? Did you rush the alignment?
Well, I'm always running late when I have a resident, but I'd never rush the alignment. So if we look at the photo at the end of surgery and day 1 post, the patient was aligned at 85 degrees where they needed to be. So I try to be as meticulous and as careful as possible in both my pre-op planning and in my aligning in the OR to make sure the lens is well centered, to make sure that there is capsulorhexis coverage, and to make sure it's aligned at the proper axis. Because what happens to the power of the astigmatism correction with the misalignment? If there is even a 5-degree misalignment, there is a 17.5% loss. So for a T3 lens, or a lens, and I'm using nomenclature here from John Burdall from astigmatismfix.com. He was very generous in lending me this slide. But even with the other toric IOLs, if you're trying to correct 1 diopter of corneal astigmatism, you will lose 0.18 diopters at that point with a 5-degree rotation. But if you are trying to correct 4 diopters, you're going to lose a heck of a lot more. You're going to lose almost 3/4 of a diopter of corneal correction. 10 degrees, you're almost losing a diopter and a half at high corneal corrections. And at 30 degrees, you've pretty much lost everything.
Well, hold on. Because I didn't have my coffee this morning, I'm a bit confused. So
But you're
you
always
say,
confused.
I'm always confused. I'm dazed and confused. So you said you picked the right IOL power.
Yes.
You picked the right cylinder power,
Yes.
and it's properly aligned?
Yeah.
So then what's the problem?
I'm just trying to educate people.
Okay.
So,
So all those three, okay.
Agent Rosa, did you use a formula that takes into account all the variables? Are you going to talk about that, or do you want to?
I'm going to talk about that, yes. So perhaps that is the mystery.
Keep it a mystery.
What formula?
Mystery.
So we're going to have you vote again. So now, after hearing so far what's happening, what now do you maybe think is going on with this? We now know that our primary cause that was voted on, a misaligned or rotated IOL, maybe is not.
Come on, agents in the field, get your phones out here. We need your help.
I think they all forgot to drink coffee like Agent Rocha.
Well, real agents don't need coffee.
We're good. Can we show the
Okay, let's show the results here after the first clue here. Okay.
It could still be poor calculations, could be corneal surface disease, and it could be surgically induced astigmatism, but many of you think it's posterior corneal. So, well, let's see, let's move forward. So what happened next is...
Is that the topography you used, honestly?
No.
Okay.
In fact, when I saw this topography, I went, let's take a step back and not use our TORIC results.
So this is from the patient.
This is the
not
original topography
presentation
from the patient.
Okay.
And so you can see that the placido disc is irregular. You can see that there's a real hot spot on there. So this is not something I would have ever based my TORIC calculations on.
Okay.
So in fact,
But
I went back.
hold on. You always get a topography.
Always get a
topography.
topography
Okay.
on any toric IOL patient.
Perfect.
In fact, we get a topography on every single patient, to tell you the truth, which is a great way from our debate yesterday, which I won.
Nobody was there.
To see if a patient had post-LASIK, a post-LASIK type of cornea. So I looked at it. There was some coma, and looked at the patient had epithelial basement membrane disease. On looking at it further, so we did, for better, more consistent results, we did superficial keratectomy, and then waited a month and repeated the results.
Okay. So, yeah, I mean, this is an important thing. The topography has changed a lot. There's still a little bit of a hint of something there, but you were a bit more comfortable then with your
Right, with my
measurements.
topography and my
Okay.
measurements. So let's move on. So now what do we think is the most likely cause of residual astigmatism? This is our last audience polling vote. Again, corneal surface disease with inaccurate measurements, misaligned or rotated IOL, posterior corneal astigmatism, poor calculations, or surgically induced astigmatism.
We're getting to 30. All right, let's see what the audience says here. Okay.
Ooh, okay.
Okay, so some of you still think I missed the boat on the cornea. Well, did I?
So, Special Agent Braga-Mele, let me ask you a question. You've done all these special tests, the IOL Master, the topography, but did they even correlate?
Well, in fact, they didn't.
Okay.
They didn't correlate. You can see here that the IOL Master and the topography were a little bit off, but we repeated testing first once the corneal surface was optimized. And what I tend to do is use the IOL Master for magnitude and the topography for access. I will not use the IOL Master's access at all. But if you're still uncertain, I suggest that you do more testing. Okay? So any ideas? So far, we can conclude that the IOL is on the intended axis. I use generally good quality measurements and appropriately manage discrepancies between the diagnostic devices. So what do we think the main issue is? You all voted on that, and the main issue was to consider the posterior cornea. You want to measure the anterior cornea in limited zones, and we extrapolate from that the posterior corneal curvature. Use population average, posterior to anterior curvature ratio to calculate the total corneal power. So what is the curvature of the anterior and posterior cornea? And Doug Koch presented this at ASCRS, and he is the leading thought in this. The anterior cornea, 51% are steep vertically, and posteriorly, 87% are steep vertically. And against the rule, astigmatism is induced by the posterior cornea in these cases, up to 1 diopter. So what is the effect of the posterior cornea being steep vertically? So it creates net plus power along the horizontal meridian. Therefore, posterior with the rule astigmatism functionally acts like ocular against the rule astigmatism. So with the rule corneas have an average of 0.5 against the rule astigmatism added onto them, and against the rule corneas have an average of 0.3 against the rule astigmatism from a steep posterior cornea. But both can be up to 1 diopter. And higher amounts of with the rule anterior astigmatism mean more posterior with the rule astigmatism. So our patient, in fact, Dr. or Agent Ahmed, you asked the right question. Did I use the right calculation? And we did not take into account the posterior cornea when we did this. This was before the Barrett formula had come out. And those with greater with the rule anterior corneal astigmatism, which was my patient, he had, remember, what we thought was 3 diopters of corneal astigmatism with the rule, will have greater amounts of posterior with the rule astigmatism. But the amount is still really uncertain. We're guesstimating in that.
Just one question.
Yes.
Which IOL Master do you have?
So this was an IOL Master 500,
So 500.
but the IOL Master 700, which we are getting, is better.
You don't have it?
Not yet.
Where do you practice?
In Toronto.
Okay. Because I've been using the IOL Master 700.
Do you love him? I don't like him anymore.
In the middle of the prairies.
Team Discord.
I decided, I'm sitting over here. I'm sorry, I have to move.
But
Sit with my friends.
all right. But no, the point I want to make for the audience is I think it's an important. Would you change your approach on selecting the axis?
I don't
when
select
you
the
have
axis from the IOL Master. I said that. Were you awake?
But yes, I was. But what about the?
We're a team. We're supposed to be a team here.
We're a team. It's not a debate anymore.
Every team needs a bit of a thorn.
But exactly. But no, I think that's an important thing. IOL Master 500 versus 700 and LensStar in terms of selecting and planning toric lenses. I think that's an important.
So in fact, I use topography, I use a pentacam, and I use manual case, which I really like manual case that are done by my senior partner who's been doing them for 20 years. The IOL Master is actually the last thing I look at for me.
Okay.
And so I think that's very important. And what Guillermo's saying, with all due fun, is that we need, with toric IOLs, the hardest part is not aligning the lens in the OR. The hardest part is making sure you have picked the right lens for that patient pre-op, looking at the corneal surface. We all walk through this today, making sure we understand what the cornea is giving us, making sure that we have done all the appropriate testing, and we cannot base it on one test alone. Correct?
Exactly.
We can't, because that will be a problem, and we will not have good results. We might get lucky every once in a while, but we won't have good results. So what's really important is posterior corneal astigmatism is real, and we're seeing it more and more unmasked. Optimize pre-op and intra-op testing if possible, and like we've just said, use the appropriate calculation. So really an excellent point from you. Thank you. So topographic measurements of total corneal power, there are some devices that will help you do that, the Pentacam, the Galilea, and OCT devices that are out there that can help you measure or get closer to total corneal power. And what's the best way to calculate toric IOL power? Well, all the toric calculators now have the Barrett formula, and I urge you to use the Barrett toric calculator on either the Alcon, AMO, or BNL websites that have the toric IOL calculators on them. The Baylor toric nomogram is also good. Doug Koch has done that one. And the online toric calculators, with respect to the ASC website, Barrett toric calculator is on there, and it is also a good one to use. It is now built into the LensStar and the IOL Master 700. So those are both good technologies to have if you're looking into new technologies and investing in a new technology. They do take into account the posterior astigmatism and effective lens positioning. But what I will say is, if you remember that slide where I said 87% of corneas are steep vertically, well, what does that mean? 13 to 15% are not. So we're now using the Barrett formula for 87% of our cases, but the other 15, we may now be overestimating posterior corneal astigmatism. So really, intraoperative aberrometry is probably the best way to help with power and alignment. Do you have an aura?
No, I don't. But how often do you need to change the axis when you use the aura compared to your pre-op calculation?
So the aura is probably better at changing the power.
So you don't really need it for the axis then?
Are we going to arm wrestle?
No. I'm just curious because I don't have the aura. But it makes sense that it would help with the cyclotorsion and everything.
I would say. I mean, remember, we also don't know what the surgical astigmatism is when we make the decision. What is it? We kind of assume a centroid value.
Centroid value,
right?
Almost
0.1,
zero.
whatever it is. So, but there's a large standard deviation. So I think that I do think there's some value in having that.
I've had a little bit of rotation occur, like 5 degrees of rotation has occurred. But where I've seen the jump, and it is the leap of faith, like I said yesterday, it's sometimes you go from like you've planned on a T3 and you're putting in a T5 because that's what it's telling you to put in, and you're going, oh my God, what do I do here?
And that has worked well.
And it has worked well.
It has worked well. So there is some value to this. I mean, there's certainly,
and there is a learning curve with it. There is a learning curve with it, but once you get on, and I don't use it for every single patient, but it is a good feather in our cap, let's say. Because I like to say I'm a belt and suspenders type of person. I like to have multiple things.
And how much time does it add to your surgical?
This gentleman was very happy when you said that, belt and suspenders.
How much time do you think it adds to your case once you get used to it more?
A couple of minutes, minute.
Okay.
I think once you get slick with it, we had our residents doing it with us, actually.
Yeah.
I had my first day with the aura recently, and it adds a couple of minutes every case, but you get faster every case too. Because you learn how you're using the applanation lens there.
Okay.
And it does get faster.
Yeah, it's maintaining. The hardest part, I think, is getting the eye at a good consistency, because you don't want it overfull and you don't want it too soft either.
Good.
So final outcome was the patient had further testing and calculations using the Barrett calculator, given option for IOL exchange with a T8 IOL versus a T7 or laser vision correction. Also given option of intraoperative aberrometry. So he decided on an IOL exchange with the same power, correcting for 3.5 diopters of corneal sill aligned at 85, and 1 month post-op. He was essentially plano, and uncorrected vision was 20/20, and we ended up with a happy patient. So thank you, everybody, for your help.
Good.
Thank you very much. So Agent Braga, one question though. So one way to do this would be just to run the Barrett calculator and see what it shows. But of course, you can also use the refractive suite, the Barrett refractive suite, or astigmatismfix.com to sort of back calculate it. So I think doing both is probably a good idea. See what the original calculator would have done, taking into account that, but then also with the known power in the eye, use, like you said, Astigmatism Fix or the Barrett refractive suite to give your power.
Correct.
Excellent. Any questions from the audience, from the investigative audience group? Oh, question here. Thank you. The question was on the refraction originally, the spherical equivalent was plus 0.5. And when you exchange the lens, would you take that into account, addressing the spherical equivalent, not just the cylinder power?
I just redid all the calculations and came out with that number, and it turned out okay. But
it's a good point, though. You're right. I mean, sometimes we
point.
only focus on the cylinder, but if the spherical equivalent's off, then just simply correcting the cylinder may not be enough, is what your point is. And even rotating a lens, if we do that sometimes, I always look and see if I rotate the lens, I may get the cylinder down to 0.5, but what would my spherical equivalent be? And if it's going to be off a bit, then simply rotating it may not be enough. So it's a good point to mention as far as looking at that as well when you talk about managing these torics that are off. Good point.
Exactly.